Eve, hello, welcome. Um, so tell me why you're so passionate for patient and staff safety and your journey to where you've got to now.
Oh, well, gosh, my passion for staff safety was actually born out of frustration, which sounds quite negative, doesn't it? But actually incredibly positive. So frustration with organisations making decisions based on finances as opposed to patient and staff safety. And that was really the heady days of turnaround rather than a rather much more glossy way of phrasing transformation. But that whole idea of almost death by 1,000 cuts and not about what that would actually mean for the staff on the ground or even the patients. No one ever asked. It was just, if we remove X amount, then we'll be able to make £10,000 per ward, or we can save £50,000 here. And just not paying attention to the stuff that we know, which is poor quality care costs money. And if we don't focus on staff and patient safety, it costs us more. So why start with death by 1,000 cuts? Why not concentrate on improving our patient and staff safety, and then we've surely got a win-win.
So what you did was kind of go, it's not going to work on the basis of what we're doing now. There are some ways of thinking that need to be changed, and we need some alternative ways of working, and you helped create some of that.
Yeah, so yes, going into somewhere and saying, okay, well, what I need you to do, Eve, is we need to save £5 million in nursing, biggest budget, off you go. It's like, stop. Let's look at things differently. Can we look at care levels first of all? So what care do we need? Let's break through the words around we must and this is in. What care do we need? And how are we going to provide that? And then how many staff does that need? So looking at care levels first, then looking at costs, then looking at the number of people. And after doing this a number of times, I ended up stopping and saying, well, okay, can I do something? Can I create something that's going to make that easier? So working with a colleague, created a tool called Establishment Genie that is about workforce planning, bringing clinical and corporate colleagues together to look at workforce planning and safe staffing and outcomes in order to design workforces that make sense. It's used across all settings of care, and it's been just an amazing experience to be able to use that data and use those outcomes to change the conversation, but also to show the impact of, if we really focus on that and we focus on the right number of staff and our staff well-being, that actually the patient care that comes out and the quality improvement that comes out, and really involving our staff in those conversations, is absolutely huge. So that's really where it came from, is just not allowing that level of ridiculous decision making around finances to happen, and actually having informed discussion where you can say, you know, would you want your mother to be looked after on that ward or by that team? And if the answer is no, then what are we going to do about it? And that just absolutely is a game changer.
Great, thank you. And so someone said to you, right, what do we mean by staff safety? What does that look like to you? I mean, you've talked about, you know, it's often talked in terms of safe staffing levels, but it's much broader than that. So what's your take on what safe staffing, what does it look like?
So it's really interesting, isn't it? There's just not enough research out there. There's a fair amount on patient safety, not enough. I hasten to add, not enough. There's a fair amount, but there really is very, very little on staff safety. And often what we mean by staff safety is safe staffing. And we know there's stuff around mandated staffing levels, campaign by the RCN to have that happen, but actually it's more than that. It's talking about making sure we're looking at the whole picture, to make sure that our staff feel valued, to make sure they understand their role in the organisation and how they participate to that whole, to make them feel supported, to have a culture where there is no blame so they can speak up and they can do things that make things better. Because actually, if we really think about safety and patient safety and staff safety, the people who really understand it and where there are holes and gaps, the people who are working on the front line. And if they don't have the confidence or the support to talk about it, and I mean warts and all, those best organisations don't hide behind gagging orders or repeat. They speak openly about what has happened and what they're doing and how they've learned from it, and take that information and learn from it. So that's part of it. I think that we know that our nursing staff experience higher sickness levels than any other group. So why is that? It's not just about not having the right number of staff on a ward or in a team. There's the other pieces that go with it. That, you know, is it because they didn't have the right PPE? So they've been sick during COVID. Is it because they haven't had the right training? So maybe they're off sick because they didn't have lifting and handling training. It wasn't given enough time. Have they been listened to when there's been a problem? Is it stress? Is it about their mental well-being? Is it about the environment they're working? You know, we know right at the moment there's an awful lot of anger. And so nursing staff, our care staff, our clinical staff are often absorbing that. Who's helping them with that? And who's helping them with some of their experiences over recent times? So safe staffing and staff safety are slightly different things. I think there's also something that says we know that the experience of our healthcare staff is absolutely strongly connected to the way they care for their patients. So we also know that staff who are consistently cared for themselves provide better care. So those organisations that prioritise staff health and well-being perform better. They have improved patient satisfaction scores, they have stronger quality scores, they have better staff retention, they have better outcomes and lower absence levels. So why wouldn't you invest in that? Now, we know that we haven't got enough nursing staff, we haven't got enough doctors, we haven't got enough of all of those things, and that's not going to be cured overnight. So how do we do things differently? How do we work with our clinical and non-clinical staff differently to do our best to change what that looks like, but also to make sure that they're safe and secure and comfortable and cared for in their role so they can provide the best possible care too? And that's all part of one bit. So safe staffing and staff safety isn't just one strand. Our health system is too complex. It's many, many things, and we need to be cognizant of all of those things in order to make healthcare a great place to work, but make our staff want to stay and want to continue providing the best possible care.
So thank you. So from what you've seen in your variety of different roles, working in consulting as a healthcare leader and now with the Establishment Genie, what do you think are some of the areas where we could improve patient and staff safety? If you had your magic wand with 3 wishes, what would they be?
Oh, how many times have you heard, I mean, well, there's 2 things really. When the phrase, you know, patient public involvement or engagement come up, how loudly do you hear the eyes roll in the room? So there's one of those, and how often have you heard that, well, if we didn't have to deal with the patients, then our job would be easy. You know, really? So when we talk about patient engagement, often what we mean is we sent out a survey and we changed the menu options because more people wanted jacket potatoes. When we're talking about patient engagement and public engagement, this is right at the beginning. This is in the design phase, not some random feedback loop at the end where we say, oh, do you actually like jacket potatoes? This is how do we design something around you and your needs? Because actually, this is all about you as opposed to us telling you. So there's something there, and I'm smiling because, you know, it's really hard. It's really hard to engage patients. You know, generally speaking, people experience healthcare when they're sick. So it's a really tricky thing. So how do we do that differently? And how do we move away from that tick box? Did we engage patients? Yes, we sent a survey. Or we emails and 3 people responded, and that's what we're building our entire response on, is the 3 responses we got. So that drives me bonkers. So if we could get that done better, that would be brilliant.
I know I should be asking you questions. I'm going to have to comment because this week I had an outpatient experience myself, and I'm all fine. But the experience which I am writing up for a blog and for the benefit of the chief exec of a large tertiary hospital in central London, they sent me a text message. How was your experience rating 1 to 6? So I said 4 because clinically it was quite good, but the whole the risk side of it was all it was not so great. And so I rated it as 4, and then I got an automated response saying, would you like to tell us why? And I said, yes, I will, but give me an email and I'll write to you. Nothing.
No. And there's nothing worse than being asked for feedback and then either not being able to give it or not hearing what happens. It goes into that feedback ether. You're like, well, if you're not going to do anything with it, and again, it's actually, that leads into my number two. My number two of what I would change is around celebrating and communicating success. So again, it's really interesting. How do we communicate? If we've asked you for feedback and you have or haven't given it, you know, if you haven't given it, it probably tells me something. But if you have given it, what do I then say back to you? What do I tell you about that? Does it just go into the... And then we can say in our survey, we sent out surveys and we received 500 responses. There isn't a bit that then says, well, what did they say and what did you do about it? But I can say that I got 500 responses. Tick. I know. And the other piece is, you know, it's like incident reporting. And I really remember at the beginning of my career, you know, the piece, you know, the number of incidents reported with, this is dreadful. And I said, no, this is a good thing. This is a really good thing, because if we're reporting stuff, we're capturing it, we can learn from it, but also the likelihood is we're having less really serious issues, and the stuff that's being reported, it's interesting around, you know, healthcare support workers and nurses and who reports what and all of those things, really interesting stuff. But if we're just saying, yes, we know what we're doing because we put some information on a staff notice board about number of incidents reported that nobody sees, it means nothing.
No.
If we're sharing what's going on, warts and all those really rubbish things that happen, because they do, those near misses, all of that stuff, are we sharing that? Are we learning from it? Are we sharing when somebody has come up with a great idea that we've implemented? How are we doing it? Where are we doing it? Because actually by doing that, that gives a really great message. That gives a great message to our staff, to the patients who use our services. If we're talking about it, they know we care. We know that we care, and everybody knows that we care. They know that we're going to make changes and it's going to be for the better. So again, why wouldn't we tell people?
And why wouldn't we share that learning, not just only within that organisation, but more broadly?
Everywhere.
Obviously, big plug for Patient Safety Learning Hub at the moment. But,
yes.
But you have to find vehicles for sharing that knowledge, and it's not easy to do that.
No. And there's so much rich information out there that I think people can sometimes feel overwhelmed. But if you know that it's related to your organisation and something that you did, and you know that without fear or without prejudice, you can go and explain something that's happened, or you can go to a patient, you can talk about those things, and that organisation will support you and they will make a change, as opposed to saying that they've created an action plan. I mean, I have read more action plans than you could possibly imagine. At no point have they changed the culture of the organisation for the better, because they have been done unto the staff. Whereas actually, if you involve the staff in, it's kind of back to the beginning of our conversation, we involve those people in making a difference, and they're engaged in that difference and know what they're being measured on and knowing why, that's when great stuff happens, as opposed to this very tell and control kind of environment, which doesn't change anything. It just means people are secretive and they hide things. So how do we change that? It's absolutely about celebration, about communication, and involving patients from the beginning and not at the end as an afterthought.
They shouldn't be magic wands, but they are.
It sounds so boring, doesn't it? I would love to think after 15, 20 years of working in healthcare, and gosh, 7 years of Genie work, you know, 2 years of research, and then the 5 years to build it to what it is today, that I would be able to say, all you need to do is, and it's not, it's really, it's boring, basic, involve people, communicate, talk, and actually it's what we fall down on the most.
And you've no doubt, for your own experience over those years and recently, have got examples of where organisations are doing that and are doing that well, and could be real beacons of hope and inspiration for others.
Oh, absolutely. And the difference, the real difference. So at the moment, I'm using appreciative inquiry to capture people's stories after COVID. So part of the Genie data is capturing, well, where were we before? Where, from a staffing point of view, what happened during, and what did we learn? What was different? What changed? And it's building on that positive core. And absolutely, I can see just by having those conversations, and everybody having those conversations, people saying, well, this really worked for us, or we did this differently and it made me feel, and we did such and such. It changes everything, and that buy-in and that feeling of being part of something great means that those changes are sticking. And again, we see the people plan. It talks about keeping hold of the good. I also have some examples of where the good is absolutely, people do not want to hold on to it because actually what it's meant is change. So I can think of 2 examples where in a larger acute trust, some of the stuff around doing virtual ward rounds with critical care staff, all of those kind of things are being scrapped. And they're changing because the team don't want to work in that way. They quite like the walking around and the touching and feeling. It's interesting. It's really interesting. So why is that? Is that because it's going back to a place of security? Because actually, I know that the outcome measures were better working in that virtual way as opposed to the team going around and doing the outreach. So it's interesting. You know, obviously anecdotal stuff, but I know where things have really worked, where those stories are being shared and things are being done differently, and that's moving around a group versus the I don't really want to change and no one's going to make me do it, and so I'm going back to the way I did things before. And I think that's just a huge shame.
And I think you talked before about the importance of research and the need to move from appreciative inquiry, from stories, from anecdotes, valuable as they are, but to have a data and an evidence base for different ways of doing these things.
Yeah, absolutely. And capturing different models of care, capturing the outcome measures over the top, doing that over time and with the same organisation 3 or 4 times. So some of the work I do with some care homes, I've been working with 50 of my care homes for 4 years now, and 4 years worth of data, and seeing how the trends have changed and the staffing levels have changed and the impact that's had on their staff retention. All of those things is absolutely fascinating. And then sharing that amongst the group and saying, well, this is what the benchmark group looks like. This is what's happened here. This is what happened here. This team moved to shorter working days. This team implemented a twilight shift. This team implemented an assistant practitioner role, whatever it might be. And this is what happened. And you can see that. And it's just amazing because one size doesn't fit all, and leadership's part of that, culture is part of it, numbers of people, different roles, they're all part of that very complicated web that we have. Gosh, relationships with other organisations, incredibly important. Attitudes between different organisations. And I know we've spoken before about almost a hierarchy of nursing that says, well, if you're a care home nurse, you're nowhere near as good as a nurse that works in A&E. Oh, but a GP, nurse practitioner, oh, well, no, absolutely not. And you hear nurses speaking about each other in that way. And you know what was the phrase? I love this. It's the piece that says, "Oh, you're a care home nurse. Couldn't you get a job anywhere else?"
Oh no!
Hold on. Where does that attitude even come from? How would you know? You've not walked in those shoes. And why would we do that to a colleague who shares the same professional group? I mean, it's beggars belief, and that's not just nursing. I've seen that with colleagues in consulting, all sorts of things. We do that to each other, whereas actually we should be thinking about what do we bring to the table, where's our unique piece, and how do we share that appropriately and in the best way for the care of the patient.
And I think some of the insights we've had during the early stages, certainly of the pandemic, were about people breaking some of those barriers down and working in a very outcome focused way, working more effectively as a team. And do you see some of that continuing, or do you think some of those initiatives are going to be more fragile than we would like?
I hope they're not going to be fragile. But I've really seen where it has been so successful, and attitudes have changed. I mean, one of my care home groups implemented a nursing associate role, a band 4 role, and it was absolutely the registered nurses as part of the group absolutely hated it, thought it was inappropriate, all of those things. During the pandemic, that has changed, and I heard 3 of those nurses as part of our roundup call say, you know, this is the best thing that's ever happened to our homes. our nursing associates were amazing. It sends goosebumps because the change, because everybody proved their worth and their value to the organisation because they worked differently. It wasn't about, I am a band 4 and you are a registered nurse, or I am a this and you are a that. It was brilliant. Susan can do this and Viv can do that, and actually could you do such and such, and it became about names and skills, and as opposed to roles and bands. And that is that's groundbreaking stuff for this organisation. How cool is that? It wasn't about hierarchies, it was about the care of the patient. Brilliant.
Fantastic. So what advice have you got to organisations to keep their staff safe?
Listen to them, communicate with them, be open with them, sit down. Don't sit in your ivory towers in a corridor that's somewhere elsewhere. Don't pretend it's not your problem. Have the conversation. Talk to your patients. Don't send them a survey where they put a smiley face in. That tells us nothing. Sit, talk to them, engage them. They might even want to join as part of your trust in order to design services that work. That would be really novel. So absolutely my advice to organisations is think and listen. Be compassionate leaders. Think about flexible working. Do a temperature check with your staff and find out if they're okay. Look at your sickness ratios and find out why. Don't frown and shake your finger and tell your operational manager to go and sort it out, or get HR to do back to work interviews. Let's have a conversation, get people to really discuss what's going on. So it's being human. It's humanising that. Right now, we know that, gosh, our healthcare staff have had a number of safety risks. You know, there's risk of being infected. They're working in stressful environments. There's a stigma attached to some health workers. You know, oh, if you're working in health, you're carrying the disease. Are you COVID? I mean, I've heard it even just on public transport. And it's very odd, this kind of reaction. So are we checking in with people to make sure that's okay? But also, are we checking in with our public? Make sure that they're okay too, because there's a way of managing this together and having that conversation. So yes, I like talking, as you may know. So organisations talking to their staff and talking to the patients, wouldn't that be great? We'd have more people talking like me.
Fantastic. So last question, how do you think we can help in patient safety learning?
Well, I think the hub is already amazing. I mean, I think having an opportunity to share those and share some of those stories, and I know at the moment it's relatively small, but it's growing all the time. I think that's really important. I think helping organisations at the top really understand that patient safety is integral, staff safety is integral to their organisations performing well, and it will save them money. And linking that, I think it's having those conversations at the top level and showing and helping to put the evidence together that shows that actually this will improve outcomes, but also save money and all of those other things too. In a world of finite resources, both physical and financial, how do we do things differently? Actually, I think patient safety learning have a huge part that they could play in that, in rattling those cages and getting people to listen. You could be the ear trumpet to help you.
Yes, and I've not heard the hub described as the ear trumpet, but I think that could be, there's a visual symbolisation there that could be really helpful. Thank you. So is there anything I haven't asked you, Eve, around safety and around staff safety that you'd like to add? Because you've given us a huge, rich insight into your experience and your perspective.
I think the only thing that I would really, I think we're a long way in many organisations from what I would term a culture of safety, where it's okay, and that makes me feel really sad. I think that's a really sad thing, and we won't change and we won't improve until we reach that culture of safety. So I think to add on to that bit of what else, if I really consider it, patient safety learning, helping people, helping organisations to understand what a culture of safety is and helping them implement that, and whether that be through a framework, however that might be, or accreditation, that could only be for the good of everybody.
During certainly the early stages of the pandemic, people were really attending to staff well-being and staff safety, obviously for obvious reasons. But what was your experience of what you saw was happening, and how well was that received, and what impact has that had?
You know, I have seen some organisations, they have just had the most wonderful response to their staff. They care, they've had helplines put in, they have put champions in place, all sorts of things, just brilliant responses. Mental health trusts offering their support to all of the organisations in their footprint. I mean, how cool is that?
Yeah.
And whilst not everybody has taken it up, that resource is something that's there. And I think that's wonderful. And I think as time goes on, actually more of our staff will need to use that. Now that kind of burning emergency stuff's gone and there's a reflection on what that actually means. There's something there. But equally, and I'm smiling just because it's so nuts. It drives me absolutely bonkers. I was speaking to a colleague in one acute trust who in response to COVID had put wellbeing spaces, they put breakout rooms, free coffee machine, water machines, all of those kind of things. And you know, this is something almost unprecedented, and the staff kind of thought, oh my goodness, they really care. They've taken them away. They've taken them away. So you did have all of this stuff, and now that the peak of COVID is gone, we're going to take away your tea and coffee in your breakout room because we did really care about you, but not so much anymore. I'm just like, what?
Yeah.
How much money have you saved by taking away that coffee machine? How much ill feeling have you left? And what does that say about the way you care about your staff? I mean, that is the death by 1,000 cuts that I was talking about earlier. I mean, how daft is that?
It's not. I mean, what happens? Do you kind of wait for a second spike or a winter flu spike and then bring it back in? You know, is it only at times of peak emergency, but normally we don't care enough?
Yeah, exactly. Oh gosh, yes, actually you're seeing that many patients today, so you must be exhausted. You might need a free coffee now. It beggars belief. I just can't. I mean, it kind of reminds me of those heady days of turnaround where suddenly you found everyone in the office was the stationery budget had been cut, so 7 people were sharing one stapler. And you're like, so the effort it takes to get up from your desk to walk over to use that person's stapler, obviously the cost of the 99p stapler isn't. I think you're moving deck chairs on the Titanic here, people. Let's really think about what's important. And you know, that absolutely illustrates beautifully what care of our staff should really mean and what not caring actually looks like. Crazy, absolutely crazy.
Well, thank you for sharing that one. Gruesome example. I mean, yeah, it's not often I'm speechless, Eve, but that gets close to it. Why would you put that stuff in and then go, nope, don't need it anymore?
Yeah.